It's Thursday, October 17th, and this is the Daily Medical News, where we bring you the top headlines in clinical medicine, plus an in-depth look at today's biggest story. I'm Molly Collegio.
And I'm Nick Andrews. Today, women taking SSRIs may experience reduced fecundity and a lower live birth rate.
Why you should consider off-label drugs when treating methamphetamine use disorder.
Don't let knowledge gaps keep you from using osteoporosis drugs to prevent fractures.
And ankylosing spondylitis and axial psoriatic arthritis may be two separate diseases.
Plus, how you have your peers and patients address you can help reverse persistent gender bias.
Women taking SSRIs may experience reduced fecundity and a lower live birth rate than women who weren't exposed to antidepressants. Those are the findings from an analysis of the EAGER trial, which included 1,200 women aged between 18 and 40 years trying to conceive. Researchers at the Eunice Kennedy Shriver National Institute of Child Health and Human Development presented the study at the annual meeting of the American Society for Reproductive Medicine. The researchers found use of any SSRI was associated with a 23% reduction in fecundability compared with patients not using SSRIs. Patients who received SSRIs had a 53% live birth rate overall. When analyzed by individual SSRI, however, there was a significant reduction in the live birth rate for patients using fluoxetine compared with patients using other SSRIs. As for pregnancy loss, there was generally no difference between women exposed to SSRIs overall versus those not exposed. But those taking fluoxetine showed a greater risk of pregnancy loss than those who didn't take fluoxetine. Despite the findings, the researchers cautioned that no one-size-fits-all recommendation can be made for people planning a pregnancy while using SSRIs.
Methamphetamine use is on the rise in the U.S., and while there are no approved treatments for it, Dr. Larissa Mooney says several off-label medications might prove helpful. Dr. Mooney is with the University of California, Los Angeles, and the VA Greater Los Angeles healthcare system. Speaking at Psych Congress 2019, she cautioned that the evidence supporting off-label meds for patients taking methamphetamine isn't robust, and none is even close to FDA approval. So which off-label medications could be helpful? Research shows bupropion may be more effective in patients with less severe methamphetamine use disorder. Dr. Mooney notes it's a more stimulating antidepressant, and it can be helpful with concentration and attention. Mirtazapine might be beneficial for patients who are very anxious and not sleeping well. And Dr. Mooney says naltrexone has shown some early signs of efficacy. A randomized controlled trial of naltrexone is in progress. There's low-strength evidence that methylphenidate and topiramate can lower use of methamphetamine, but methylphenidate is a stimulant, and Dr. Mooney cautions that there's controversy over the use of stimulants to treat patients with substance use disorders. She herself tends to be conservative about using stimulants in this population.
Clinicians shouldn't let the lack of research on osteoporosis treatment compliance keep them from acting on what's already known about drug therapy's effectiveness in preventing fractures. That's the advice from leaders at the American Society for Bone and Mineral Research. Speaking at the Society's annual meeting, they discussed recent recommendations from an NIH workshop on using drug therapies to prevent osteoporotic fractures. While there are gaps in osteoporosis treatment, Dr. Douglas Kiel of Harvard Medical School in Boston says there's still room to act. Start by knowing how to identify patients at the highest risk of fracture, as well as which medications reduce the risk of osteoporotic and osteopenic fractures. In 2016, ASBMR put out a call to action to intensify screening for high-risk patients to prevent fractures. And the Society recently published consensus clinical recommendations for secondary fracture prevention. The Society's next step is to execute its action plan, which prioritizes reimbursement for fracture liaison services and care coordination, establishes a national fracture registry, and works to include osteoporosis fracture prevention in guidelines and education services. We'll be back with more medical news after this message.
Ankylosing spondylitis and axial psoriatic arthritis may be different diseases with overlapping features, rather than entities on the spectrum of the same disease. University of Toronto researchers say the two conditions seem to have different genetics, demographics, and disease expression. The investigators compared two adult cohorts. The first cohort included ankylosing spondylitis patients, or AS patients, divided into those with and without psoriasis. The second was made up of PsA patients and divided into those with axial and peripheral disease. Compared with axial PsA patients, ankylosing spondylitis patients were younger at diagnosis, more often male, and were more likely to be HLA-B27 positive. Over time, axial PsA patients had more tender and swollen joints than ankylosing spondylitis patients with and without psoriasis. AS patients with and without psoriasis had greater functional limitations and worse axial disease activity scores. These data appear in the journal Rheumatology.
It's a trend with which female doctors are all too familiar. Instance after instance of peers, co-workers, and patients assuming first-name familiarity with them, but not their male colleagues. It's even spawned its own Twitter hashtag among the phenomenon's female victims. My first name is Doctor. But the first-name phenomenon's not just anecdotal. Research demonstrates that female physicians and scientists are significantly less likely than their male peers to be addressed by their titles. Dr. Narges Duma is the first author of a just-published study of presentations at the annual meeting of the American Society of Clinical Oncology in 2017 and 2018. Dr. Duma of the University of Wisconsin-Madison assembled a research team that had a 50-50 gender balance and racial and ethnic diversity. The team combed ASCO transcripts to code introductions according to whether title and surname were used or whether speakers were addressed by first name only. The researchers found that men were more than 2.5 times more likely than women to be introduced with their professional title, and women were nearly 6 times as likely as men to be introduced by their first names only. When the introducer was male, a female speaker was more than 3 times more likely to be introduced by her first name only. What's the right approach when a patient, uninvited, addresses you by your first name? Dr. Natalie Strand of the Mayo Clinic offers an approach she used on a patient who wanted to address her by her first name in an office visit. Her response? Yes, but I go by Dr. Strand at work. Dr. Strand says beginning from a good point of mutual professionalism is a good place to start. She always begins by addressing her patients by their surname and waits for patients to invite her to call them by their first names. When she has a long-standing relationship with patients and she knows that trust and mutual respect have been established, she may also invite first-name familiarity. For a more comprehensive look at the issue, click the link in the podcast notes. And that's it for today's Daily Medical News. Remember to check out the newest episodes of Blood and Cancer and Dermatology Weekly podcasts, available today and every Thursday. For MD Edge, I'm Molly Collegio.
And I'm Nick Andrews. Thanks for listening to the Daily Medical News.